Am I a candidate for non-surgical treatment options? A discussion about thermal ablation procedures. My name is Lois Freed, and I am a co-facilitator of a ThyCa survivor support group in Northern California. We are called the Silicon Valley ThyCa support group. I am pleased today to introduce our moderator for this group and participant who will introduce the other guests on the panel today. Jennifer Holkem is a dedicated educator and advocate for thyroid preservation. After her 2019 experience with RFA treatment of a large benign thyroid mass, she founded Save Your Thyroid, an advocacy community aiming to become a non-profit for patients seeking FDA-approved non-surgical thyroid preserving treatment options. Due to a lack of patient-focused resources, Jennifer creates and shares educational content on YouTube, Spotify, and social media. She has the privilege of interviewing patients and experts worldwide, working to bridge the gap between patients and physicians. Additionally, Jennifer publishes patient-focused resources on Substack and the Save Your Thyroid website, including lists of known physicians who offer thyroid-preserving treatment options. She devotes a full-time effort to providing these free resources to the Save Your Thyroid community and to the public. Welcome, Jennifer.
Thank you so much, Lois. Just a reminder, please remember the information presented in this webinar is for educational purposes only and is in no way a substitute for consulting with a medical professional. And now I would like to introduce our physician speakers. So first we have Dr. Jules Aljammal, who is an American board-certified endocrinologist. He completed fellowship training in endocrinology at the University of Pittsburgh Medical Center in 2014. Thereafter, he started a medical practice in Salt Lake City, Utah, that specializes in the management of thyroid disorders. He introduced RFA, radiofrequency ablation, to Salt Lake City in 2018 and has performed more than 600 cases of RFA. Dr. Aljammal has published his work in several leading journals, including the Journal of Endocrine Society, and has been an invited international speaker. His passion for RFA and drive to advance the field of interventional endocrinology led him to create the North American Society of Interventional Endocrinologists, NASOI. Dr. Aljammal continues to work on increasing patient access to RFA and plans to open an office in Washington State to support patients in the area. And I would also like to introduce Dr. John Russell. He is the highest volume innovative surgeon in the United States. After training at the Cleveland Clinic, Dr. Russell trained further at Johns Hopkins before spending almost 10 years there. He became the chief of head and neck endocrine surgery at Johns Hopkins and was the director of the Thyroid Tumor Center. During that time, he was the first surgeon to complete transoral robotic surgery for thyroid cancer and led the largest series of transoral surgery in the West, and was the first group of head and neck surgeons to offer radiofrequency ablation, or RFA. In 2024, Dr. Russell founded the Russell Center for Endocrine Health, where he continues to innovate as he offers each patient a personalized plan of care. Okay, and I have one other speaker that might be joining us if he makes it, and I'll just go ahead and introduce him quickly. Dr. Juan Camacho, who is a practicing interventional radiologist at Radiology Associates of Florida, Sarasota Memorial Healthcare System. He trained at Emory University and has worked in renowned academic institutions for the past 10 years. Dr. Camacho has a clinical and research focus in loco-regional therapies for the treatment of benign and malignant tumors, and has developed the IR-ENT service line in collaboration with endocrinology and surgical services in the institutions where he has served. During his prior appointment at Memorial Sloan Kettering Cancer Center, Dr. Camacho designed a translational model to ablate thyroid microcarcinomas and was part of the first ablate and resect trial on the subject in the US. He is a member of the SIR, NACIT, SIO, RSNA, and serves in different roles within the societies, as well as in the American Board of Radiology. Hopefully he'll make it and be able to join us. So I have a list of questions on this topic that we're going to discuss today, which is non-surgical treatment options for thyroid cancer. Generally speaking, these include RFA and laser ablation and microwave ablation, and there may be others coming on the horizon. So we're going to just start with a general overview of what thermal ablation is and why a patient might want to choose it as a treatment for their thyroid nodules. Dr. Aljammal, can you explain the important differences between treating a benign and a cancerous thyroid nodule?
There's a big difference between the two when we're thinking about a treatment. When we're dealing with benign thyroid nodule, in general, our goal is to try to make sure this nodule symptoms or symptoms related to that benign nodule disappear. And when we're trying to treat cancer per se, our main goal is to completely destroy the cancer and make the cancer completely disappear. So from that concept, when we're treating benign nodule, we don't really care as much if we leave a little bit of thyroid tissue at the end. And on the other hand, when we're dealing with cancer, our main job is completely eliminate that tumor. So that's in general when we think about a benign and malignant nodule and their treatment. Now, in a concept of thermal ablation, we do know, or the main job when we're doing thermal ablation is delivering enough heat to destroy that tissue to make the nodule shrink after inflammatory response and destruction of this tissue start. And when we're dealing with big tumors, big benign tumors, we do expect at the end that some residual tissue will stay at the end in the neck after the ablation. So that's where, in preference, we like to treat benign nodule, regardless of the size per se, with thermal ablation without being worried about residual tissue. Versus when we're treating cancer, we prefer treating small tumors because we are capable at that point to destroy the whole tumor.
Thank you, Dr. Aljammal. Dr. Camacho, I'm so glad you made it. Can you talk with us about what thermal ablation procedures are currently now available and sort of give a brief summary of each one? And kind of a side note question to this is, why is ethanol ablation not really considered an appropriate treatment anymore for thyroid cancer?
Thank you, Jen, for having me. I think now, honestly, is such an exciting time for minimally invasive thyroid therapies. And the reason are multiple, and is that we have at the very least 6 to 7 different modalities available. So we have percutaneous ethanol injection, we have laser, we have radiofrequency ablation, we have microwave ablation, we have cryoablation, we have nanosecond pulse electric fields, and we have HIFU, which is out of these ones, the only one that is truly, truly non-invasive. So we have now a potpourri of multiple tools, and each tool actually, I feel it has its own different niches. Pertaining to your question of ethanol ablation, one of the key things with ethanol is highly effective. However, the problem is the diffusion within tissues. So you really need to have it very well contained to the tumor itself for it not to cause any harms outside of the target, number one. And number two, you have to be very careful where you're injecting, because you don't want to inject the substance into a vein or into an artery. So those are the main things why people have stayed away now from ethanol ablation. Now, in terms of what I call heat modalities, meaning the ones that utilize high temperature to burn the tissue, we have three main ones. We have laser, we have radio frequency, and we have microwave. In my opinion, I cannot necessarily sustain this with data because there hasn't been a lot of studies comparing the three. But in my opinion, since we're referring about malignant lesions under 1 centimeters, honestly, when you're using heat, I believe that the technologies are interchangeable because you're just ablating such a small volume of thyroid that you're probably going to be able to pack enough energy to ablate that area of tissue. The differences start when you're talking about benign pathology. That's when, you know, the different thermal ablation techniques, high temperature ablation techniques are going to suffer. And obviously, the high heat ones are, the adjacent structures are going to suffer with, or they're going to be more sensitive to high temperature. And that's when cryoablation has its own role. So if you're burning a lesion that is close to critical structures, utilizing cold might help in protecting those adjacent critical structures. And now we have nanosecond pulse electric fields, which is non-thermal. And we have data, preliminary data in benign pathology that says that the nerve can be protected and so the adjacent structure. So that's kind of like a very broad overview of the techniques. And I think that the main message is now it's a very exciting time. We have a ton of different tools, and I will encourage people to do research on each one of them and go to practitioners that understand the value of each tool, because you may have a tumor that is more permanently that is going to be better treated or better suited with cold versus heat. So that will be my advice.
Thank
Can
you,
I-
Dr. Camacho. Oh, please go ahead, Dr. Aljammal.
Just one point about using ethanol and tumors or a structure. There's a concept of we're talking about solid tumor versus cystic tumor. And cystic tumor with capsule versus solid tumor, where sometimes you may have a pseudocapsule or no capsule at all. And I think Dr. Russell can share his opinion about that as he deals with tumors directly when he removes them. When we're injecting ethanol, one of the caveats, you do not have a cavity to inject ethanol in an area. So when you are doing ethanol treatment, you need to target different spot in a solid tumor. And we are hopeful when we are doing that the ethanol will distribute equally and destroy the tumor equally. So that's one of the caveats of ethanol treatment when we are dealing with solid tumor. When we're dealing with a cystic component, the beauty of it, you may have a capsule that help you when you inject the ethanol to distribute all the ethanol in a kind of equal manner to lead to the destruction you're hopeful for. And I just want to point that when we're talking about solid versus cystic. And then another concept that is important when we're dealing with treatment with different methods of thermal ablation, not cryo. The cryo data I'm aware of in thyroid are limited, so I can't really talk about that as much. And pulse is still, or a treatment with nanopulse is still in early stages, so we don't really have a lot to talk about that. When we're treating with thermal, one thing that is different between all those different technology is the amount of energy delivered in the time frame. Some of them deliver energy very fast in a very short period of time, and some of them deliver energy in slow process. And maybe when we are dealing with tumor close to capsule, surface, some method may be preferred more than the other. But one important concept, which is Dr. Camacho kind of lead into, is basically the skill, the operator skill, their experience in using the same technology. Someone who use a microwave all the time, who have a huge experience in it, may be able to perform a lot better than someone else who have limited experience or even with technology that maybe on paper sound better. So it's very important to emphasize about the skill component. I just wanted to intervene in that.
Thank you so much. That was great. Dr. Russell, do you have any comments?
I've got lots of comments, but I think we're good.
Okay. For the audience, I would like to let everyone know, if you visit our website, saveyourthyroid.org, and then click on the procedures tab, we have a long list of research papers about each of these procedures that were just explained. And you can also go on that particular page and watch videos about each of these procedures as well. So just wanted to let everyone know there is more information available there. So the next question I have is for you, Dr. Russell. Please tell us, what steps does a physician need to follow to determine if a patient is a candidate for thermal ablation? And tell us also, who is the ideal thyroid cancer candidate for thermal ablation?
Thanks, Jen. And your website is fantastic. So hopefully all of our guests today have had a chance to look at it before. Some of the people that you interview sometimes are a little questionable in their character, but other than that, I think it's just truly a great website, including all of your guests today, because I know you've interviewed all of us. So I'm going to answer those questions backwards. First of all, who's the best candidate to be considered for radiofrequency ablation or for thermal ablation in general, as the other two guests just said? It's somebody. In thyroid cancer, we know that the vast majority of small thyroid cancers are not going to progress to a point where they become life-threatening. And so this idea of active surveillance has entered into the lexicon. So some patients might not need any treatment at all. Specifically, currently, the guidelines in general consider tumors that are smaller than 2 centimeters, that are known to be cancers, that are known to be papillary thyroid cancers, and that are known to be in a good location relative to other critical structures, specifically meaning not too close to any nerves and potentially not into what we call the tracheoesophageal groove, just kind of right where a lot of those critical structures live. And if you leave cancer behind, it's the most likely to cause harm. And so if you have a patient who fits those criteria for active surveillance, or just doing ultrasounds serially instead of moving forward immediately with surgery, if you have a candidate for that, then that is also somebody who we like to think would be an excellent candidate for thermal ablation of some sort. And that's a bit of using the data to extrapolate. Right now, I think all of us would agree that we don't have extremely excellent long-term data on the results of any of these thermal ablations. We're extrapolating out the fact that we know that most thyroid cancers do not cause mortality, and very few of them cause significant morbidity in most patients. And so we extrapolate out that if we treat them with radiofrequency ablation, then you should not do any worse than you would have done had you done nothing. And so in general, if you are eligible for active surveillance, then you are also eligible for thermal ablation, is kind of the easiest way to think about it. And so the same tests that you would have to determine whether or not you have to have surgery are the tests that you should have to determine whether or not you could have thermal ablation. That begins with an ultrasound. You're going to check your labs, of course, to see whether it's an overactive or underactive nodule. You might have whole body scanning involved, usually not when we're talking about cancer. The labs also are a little bit secondary when you're talking about cancer, although we do know that Graves' disease can make some thyroid cancers a little bit worse. And so that plays into all of the discussion that you're having with your doctor. But in general, once you've done all of this, then you move on to the biopsy. And again, we talk about the Bethesda classification of a biopsy result. Usually your biopsy is done with a fine needle, smaller than what you use for a blood draw. But after you've done that biopsy, the cells will be either benign, cancer, or indeterminate. If it's benign and it's very small, you probably don't need to do anything at all with it. If it's cancer and it's very small, you may not need to do anything with it. And then there's the group in between that are indeterminate nodules. And that's something that we debate at all of our societies. And so for the sake of today, I think we say, if you're Bethesda 5 or 6 and you have a very high confidence that you've got a papillary thyroid cancer and it is small enough and in a good enough location that you could just watch it, then you are probably a good candidate for thermal ablation.
Thank you, Dr. Russell. Excellent explanation. Okay, on the other side of that coin, Dr. Camacho, tell us who absolutely is not a candidate for thermal ablation, talking about the size of the tumor, the location, the genetics, etc.
I will say, first of all, that more than a candidate or not a candidate, I will say that there's appropriate patients for ablation and there is inappropriate patients for ablation. And right now, one of the realities and one of the things that we as doctors that are part of many medical societies are working on, it's defining guidelines based obviously on the evidence that we're building to try to help everyone in determining who is an appropriate candidate and who is an inappropriate candidate. Right now, in terms of level of evidence, there's different types of recommendations from expert consensus in the European and in the Asian guidelines. And there was a kind of like a worldwide consensus led by some of the members of this panel, actually, that was published in 2022 that also leaned in certain recommendations. So I think that that's important that right now, if we go through the NCCN guidelines, which are our national guidelines, there is no recommendation to treat cancer with thermal ablation. Now, if you go to the European guidelines, the Asian guidelines, there's very strict recommendations based on the currently available evidence. So the appropriate candidates for this procedure are patients with micropapillary thyroid cancer, which is the earliest stage thyroid cancer. Ideally, all of these nodules under 1 centimeter in size. And the appropriate and it's not everyone that complies with that pathology. It's a combination of things, right? It's the size of the tumor and the location of the tumor. It's like real estate. That's the most important thing. It's location, location, location. So Dr. Russell was explaining us earlier about the tracheoesophageal groove and those posterior locations. Those are the ones that we try to stay away from. That doesn't mean that it's completely inappropriate to do. In very skilled hands, in patients that have in physicians that have done this several times and they have advanced training and they can do hydrodissection to protect those critical structures, it may be appropriate. So that's kind of like a gray zone. But the ideal patient is those tumors that are smaller than 1 centimeter and that they are located predominantly anteriorly in the gland, far away from critical structures, and that obviously are patients that are eligible for active surveillance, which in the vast majority of those are those who have early stage disease, meaning micropapillary thyroid cancers.
Could you touch on also the other kinds of thyroid cancer, medullary, anaplastic, follicular, and if those are definitely off the table for thermal ablation?
That right now, yes, there is no evidence that we should be entertaining ablation of anaplastic thyroid cancer or medullaries or any other type of cancer that is not early stage papillary thyroid cancer.
Thank you. Okay. Our next question, Dr. Russell, can you discuss how thermal ablation is an additional step before a potential surgery rather than a replacement for it?
Yeah, I actually really like this question. I think it goes back to what we know about thermal ablation, what we don't know. And there's so much that we don't know about the long-term outcomes. And so really, once you've been treated, it's as if, I think most of us tell our patients, it's as if you still have cancer, even if, and sometimes it does totally disappear on ultrasound, but you're not relieved from doing your regular follow-ups as if you were in active surveillance. And so, 5 years from now, are you going to see that start to grow back in some of those areas that Dr. Camacho just talked about, where it's a little bit posterior, and at that point, you're not going to feel comfortable moving forward with surgery? I think patients just have to understand. But I think there's a lot of value in feeling like there's another option if you're a patient. It's very satisfying to go into the doctor and hear you have choices, and you don't have to rush right into surgery. We could do active surveillance. We could do radiofrequency ablation. And it kind of gives patients a sense of satisfaction that they get to drive the ship a little bit more than, but you're not out of the boat. Surgery is the only one that kind of gives you that more definitive answer. Otherwise, you have to act like you still have cancer.
And it's also a common myth that we see in the Savior Thyroid community that patients who undergo radiofrequency ablation in particular are often counseled that once they have that procedure done, their surgery is going to be just an absolute nightmare. And so I don't know if you have any comments on that as a surgeon yourself, Dr. Russell, but this is a dispelled myth, hopefully, at this point in time.
Hopefully. It's certainly, so having done a few of these, there is some scar tissue, but I think it's definitely a big stretch to say it's an absolute nightmare to do it afterwards. It's really hard because as doctors, we really try to protect all of our patients, but sometimes when we don't have good information, we're protecting them from things that aren't necessarily true. And sadly, that happens.
Can you tell us then, Dr. Russell, about, is there a place for a combination of surgery and thermal ablation?
Yeah, there is definitely. Either if you're temporizing, you've got an event that you just want to get yourself through that event, and then you want to move forward with surgery. And then rarely we'll have situations in which patients have tumors that they would like to treat with. In my specific case, I've got a few patients who would like to consider scarless thyroid surgery. And by doing some sort of a remote or some sort of percutaneous treatment, whether it be thyroid artery embolization or radiofrequency ablation or some other thermal ablation, you can shrink the size of the tumor enough that you could consider some of these alternative surgical therapies so that it's less obvious that you had thyroid surgery in the past.
Thank you. Okay, so this next question, we're going to involve all three of you. We're going to discuss the process of thermal ablation for primary thyroid cancer, metastatic lymph nodes, distant metastases, and inoperable thyroid cancer. So let's start with you, Dr. Russell. Talk us through the process of thermal ablation for primary thyroid cancer as far as treating that nodule in totality. And I'll just let you take that.
All right, stop me if I get off topic. I know the other two will correct me on the other areas at least, so that's good. So as it starts in the office when you do an ultrasound with the person who's going to do your thermal ablation. They have to evaluate and make sure that you're a good candidate. The next thing that everybody always wants to talk about is hydrodissection, which is a critical skill if you're looking to protect those structures. And the reason for that is you start off with an idea that your tumor has to be in the perfect location. Thyroids are not huge usually. And if you've got a small tumor in a not very big area, it's pretty easy to abut these other critical structures. But you can do things to help as long as the tumor is in the right spot. And one of those things is hydrodissection, where you'll inject, usually it's just sugar water. We call it a fancy name, but it's just sugar water. And that creates a buffer around some of those critical structures so that you can not only treat the cancer, but you can treat a margin around that cancer so that you not only kill what you know is cancer, but some of those little nests of cells that likely expand out. And that leads to something that happens afterwards where a lot of patients will see an increase in the size of their tumor over the first 6 to 12 months when they get their follow-up ultrasounds. And that can be scary. And one of the things that we have to reassure people is, no, that's actually a good sign because that means we treated an extra cuff of normal tissue around your cancer. But the treatment is just like with any other radiofrequency ablation. It's similar. You put the needle into the middle of the tumor. In some ways, that you spend a lot more time positioning your needle for your first activation because you're not going to we do something called moving shot technique where you reposition the needle multiple times to make sure you've treated the entire area. But with these smaller tumors, there is usually less of that because the tumor itself is smaller. And so you want those first few strikes that you make to be just in the exact perfect location as you're moving forward. So more setup time, perhaps less activation time when you actually get treated because we treat by the volume of the tumor. And most of these cancers are only about a cc plus or minus in total volume.
Thank you. And Dr. Aljammal, let's talk through metastatic lymph nodes.
So yeah, I would like to emphasize the importance of a couple of concepts there. When we're talking about primary thyroid cancer and microscopic, when we say a patient is a good candidate for active surveillance, we're talking about patients who have less than 1 centimeter tumor. We're talking about patients who do not have lymph node involved on your first evaluation. Because you are thinking about microscopic, so if it's 4 millimeter, 5 millimeter, then it should not have lymph node. You'll be surprised. location of those tumor, if they are in the isthmus. Sometimes 8 mm tumor in the isthmus already have spread into lymph node. Now, one can argue about lymph node involvement in microscopic disease and progression and mortality rate, and the data can be kind of very encouraging that a lot of patients do well, even when we're talking about microscopic disease to lymph node. But that's very important. And exactly what Dr. Russell pointed out there, when we're talking about tumor and its location, but we also need to talk about what we call a buffer zone of at least 3 to 4 millimeter. Most of the data that is published, and the largest data from 2021, when they looked at retrospective data for closer to 400 patients with microscopic tumor, they're talking about 3 to 4 millimeter, where the antenna size itself is 1 centimeter and the ablation zone is significantly larger than the tumor itself. So the antenna itself, by just putting it in the right spot, will deliver enough what we call a zone of destruction that will exceed the tumor itself. And this is very important because at the end of the day, we're not treating cancer by leaving it in the neck. If we need to treat cancer with an intervention, that treatment should lead to complete destruction. Now, when we're talking about lymph node involvement and treatment with lymph node with RFA or other thermal ablation, we are really talking about patients who had surgery, extensive surgery, a perfect central neck dissection and lateral neck dissection. We're not talking about patients who had total thyroidectomy and selective lymph node treatment. We're talking about patients who had a full, complete dissection of lateral neck or central neck, who is a patient is not candidate for surgery anymore, or who refused to do surgery. In those situations, yes, considering thermal ablation treatment with RFA may be reasonable. The data from that show the recurrence rate post-treatment in the zone of ablation is very minimal. When we evaluate those patients, we are really choosing patients who have a limited number of lymph nodes in the neck. Talking about 1 to 3, maximum 4 in some of the studies, who have lymph node that include doing a CT scan, specific CT scan of neck with contrast to evaluate for lymphadenopathy. Those lymph nodes do need to be confirmed with biopsy before the thermal ablation, with cytology, when thyroglobulin washout. And the thermal ablation in this situation need to be done with hydrodissection, as Dr. Russell was pointing out. But here in lymph node, we're trying to create what we call an islet of fluid around the lymph node. And the point is to reduce damage and injury to structure surrounding it. And then when we are doing thermal ablation, because lymph node volume is generally around 0.2 to 1 cc maximum, you really just need to have your antenna in the middle of that lymph node. You may need to do it on 2 different spots, and then you're delivering the treatment. The outcome that we have seen in our practice and our data that have been published and internationally, around a year to up to 2 years, closer to 90% of those lymph nodes will disappear completely. You cannot see them anymore. Now, the data about recurrence after treatment with a thermal ablation, some data show, as I mentioned, locally recurrence is very minimal. Long-term data, now we have some study from South Korea looking at recurrence rate. You can see metastatic disease after thermal ablation of lymph node to the lung. The number of cases was, I think, 4 cases in the data that have been published, but that's without real good description of the initial tumor. Are we dealing with, when we're talking about tumor, is it a high-risk tumor? A patient who have already a risk of 50% recurrence, high risk of recurrence of cancer and metastatic disease. So the data does not describe that as well. And we cannot really conclude anything negative or positive from this. I can always argue with, it's still early. We need a lot more data. We need multiple center studies. We need larger sample to be able to kind of describe accurately. And we need to know exactly what type of tumor we're treating, what we are expecting if we did thermal ablation versus we did not do thermal ablation. What was the outcome? And if there is no difference, one can argue maybe there is a more role for it. But for now, it is really safe for a patient who had proper surgery, complete central neck dissection, lateral neck dissection, as per the guidelines, and then who the surgery after that may lead to more complication, patient refusing the surgery, the patient is not a surgical candidate, and then we're talking about maybe thermal ablation for lymph node.
Thank you, Dr. Aljammal. Okay, Dr. Camacho, because you do ablations all over the body as an interventional radiologist, talk with us about treating distant metastases. These are most likely not going to be papillary thyroid cancers, but they will still be treatable with thermal ablation. So tell us about that.
I think it's important to say that, you know, it's not infrequent for me to deal with oligometastatic disease from papillary not microcarcinomas, but from papillary thyroid cancer throughout the body. And it's very frequent to see metastases in the lung, in the liver, and in the bones. I will say that that's the most frequent areas that we see metastases. And at the end of the day, you know, these patients also are going to have plenty of options. I mean, there are systemic therapies, what is called TKIs. That's one of the things that is used currently in practice. Number two, there is radiation. Radiation is something also that you can offer to patients that have limited volume of metastatic disease. And you also have the percutaneous ablative techniques that we just discussed: cryoablation, laser, microwave, radiofrequency. You can not only apply them to the thyroid itself, you can also apply them to the metastatic lesions. So, and more importantly, there's other techniques that we don't necessarily have touched on, but there's all the endovascular techniques. Embolization is a huge platform outside the thyroid. Right now in the thyroid is under development, but outside the thyroid, and particularly in the liver and in the bone, has a lot of impact in patients that have metastatic disease, because it can be used as primary treatment as well. So in other words, I think that one of the most important messages from this very short intervention is to say that, number one, patients with metastatic disease, it's not the end of the world. Okay, they always have options. There's going to have actually nowadays more different options. Number two, I think interventional radiology plays a very important role in palliating these cases. And number three, it's about local control. And local control can be obtained, can be performed very safely in various parts of the body, irrespective of the size of the lesion, with a combination of either percutaneous ablative therapies or endovascular techniques. And endovascular techniques, right now we have blunt embolization, which is just clogging of the blood vessels. And we also have endovascular radiation. We can deliver radiation beats to multiple areas of the body, including the liver, and treat metastases that way. So patients do have a lot of options. And the most important thing is to do what we're doing right now. We have Dr. Russell, we have Dr. Aljammal, they're from different specialties, interacting with an interventional radiologist, and all talking about the same case, learning from each other and sharing our skills. That's the key. Wherever you go, you have to look for this multidisciplinary team of people. That's the most important thing, because that's the way that you're going to be able to get personalized care. If there's a message that we need to deliver today about thermal ablation for thyroid cancer patients, is like, it's about personalized care. Not everyone is going to get the same treatment. It's about personalized care and having these interactions among different specialties.
I couldn't agree with you more, Dr. Camacho, and I appreciate you explaining that as you did. Okay, and now we're on to inoperable thyroid cancer. Dr. Aljammal, can you talk with us about this? Because I believe don't you have personal experience with this, or am I maybe thinking of someone else?
So it depends what you're referring. I don't have a personal experience. Maybe you may be referring to someone else per se. But inoperable thyroid cancer, basically that would be a situation where the patient disease is extensive, invasive, affecting the trachea, or where you are going to end up with surgery that have more complication for patient quality of life and life compared to do nothing. So the surgery itself become more problematic. Also, a situation where you can end up with patient may not be a good surgical candidate, which is different than, is basically when they have other medical comorbidity or mortality, a medical condition that increase their mortality and risk, that the patient, if you end up going to the OR, they may have more risk for their life than the surgery itself. And that's kind of really the situation I think of. In those situations, I know there is some role for considering thermal ablation for local control and treating tumor. I know there is in some situation where they put stent into the trachea to maintain it open where you're doing the thermal ablation, but I do not have, to be honest, a personal experience in this or have patient with this situation.
Dr. Russell or Dr. Camacho, do you have any experience you would like to refer to on that topic?
I can speak for the only data that we can share, which is not extensive, data, but it doesn't involve thermal ablation, because I think that it's hard to give a role to thermal ablation in inoperable tumors. In general, in inoperable tumors, we're talking about large, bulky tumors that are involving adjacent neck structures and whatnot. And we have done embolization as a palliative intervention on those cases. And it's anecdotal experiences, it's case series is what we have. And we have done that as well in very aggressive histologies such as anaplastic cancers, but it's all anecdotal and it's the only thing that I can kind of like share. And we have only performed it in scenarios in which patients are not candidates for anything else. They're not obviously operative candidates. They don't have the ability to undergo standard of care therapies, and this is just palliative interventions.
And I will second what Juan said. These are the worst of the worst cases, and it's very difficult to extrapolate out for generalities, because each patient has to be evaluated individually, and sadly, none of them make us super happy at the end of what we do. Is kind of my experience.
Unfortunately, yes, palliative care is definitely an area that we don't want to. We won't want to frequently have to discuss, but it is something that does come up from time to time. So, okay, well, moving on. I know that all three of you have participated in some interesting research on thermal ablation for thyroid cancer. And so I would love for you to share any pearls that you'd like to with the community today about this topic. So just whoever would like to go first.
I'm happy to go first. I think what we found in our research, so we started a trial for patients who are eligible for active surveillance a couple of years ago. I think one of the first things that's interesting to me is to who enrolls in a trial like that. And sometimes it's not the patients that we think are ideal candidates, but it's kind of the borderline patients who are the most anxious to enroll in these things. And so Dr. Aljammal talked a little bit about these perfect less than 1 centimeter with 3 to 4 cuffs of 3 to 4 millimeters around. Those are extremely rare. Instead, you've got the patients much more commonly with 1.8 centimeter tumors at the posterior capsule with Graves' disease, a little bit overweight. Those seem to be the patients that are really challenging cases. And technically they meet criteria, but they're not the ones that leave you warm and fuzzy as you walk away from treating them. And so I think we've had fantastic success on paper. As you look at our research so far, our average volume reduction rate is over 98 to 99%. In my experience, we have had one patient where after treatment, she ended up having metastatic disease to at least her central neck. The lateral neck, she has a suspicious node, but it hasn't reached the size that it deserves to be biopsied so far. I think Dr. Aljammal, as an endocrinologist, would probably tell you, he alluded to, that disease had probably metastasized before she was treated. I don't think that it was new after we did the treatment. That's just not how thyroid cancer usually works. But when we saw the metastatic disease the way that it was, she felt more comfortable moving forward with surgery. And indeed, she had a slightly more aggressive version. It was BRAF positive tall cell variant with multiple metastatic nodes. And I think that's a good place to kind of comment that all of these treatments, going back to your question earlier, Jen, how does RFA funnel into this idea of a part of your treatment strategy? Any patient that gets married to an idea of exactly what they need to do may set themselves up for disappointment in the future. And so being flexible and adaptable to the data that you get on your specific situation, just like Juan and Jules have alluded to already, you've got to take that data and you have to personalize your treatment plan. And sometimes as a doctor, that means saying something. All three of us love to do thermal ablation. It's kind of our passion. But there's a time and a place. And if any one of the three of us tells you, hey, you're not a good candidate for this, you should listen, because we want to treat you with radiofrequency ablation or some sort of thermal ablation. And sometimes it's frustrating when patients don't see our passion to treat them the best way possible.
I just have one comment here. I completely agree with Jonathon about the description and all the above. And I would like to emphasize about when patients choose treatment for thyroid cancer with thermal ablation is the importance of monitoring. I cannot emphasize how much important it is to monitor. Again, when we do thermal ablation, we are not completely destroying the tumor. It's benign, malignant. We are not completely destroying the tumor. And one of the main concepts when we do any treatment for cancer is you want to get rid of the tumor or get it to a point that is below detection level. That's what we call minimally detected tumor when we're treating with cancer. Doing thermal ablation and not to have monitor or not to have follow-up or just do it because we can do it, that's never proper. And I need to emphasize, if you choose to do thermal ablation, you are a patient who still have cancer, who still, as Jonathon mentioned at the beginning still have a problem. This need to be monitored, need to be evaluated, need to be addressed, because we cannot just do a treatment and say, hey, I'm done and everything is fine. It looks smaller. I checked it 6 months, everything looked good. This is needed long-term monitor. We're talking about years and years of evaluating and monitoring. And I want to bring up a subject that may not fit in the concept of we're talking about cancer, but even when we're dealing with benign nodules, we tell patient 2 benign cytology, likelihood of malignancy is less than 4%, 3%. That does not mean we're not 100% confident there's no cancer. Even with benign situation, when you do treatment, you need to monitor. We pick up, and I have picked up patient after thermal ablation, we had cancer. The most common that usually we miss as physician is follicular carcinoma, because form of follicular carcinoma, you cannot make a diagnosis unless you have evidence of invasion in capsule. And that cannot be made or made diagnosis without surgically removing it. So I just wanted to emphasize the point, importance of monitoring, doing a treatment. Just because I can do it does not always mean the right answer. If you are in a location where you cannot monitor, where you cannot keep an eye on how things are progressing over time, this may not be the right option per se, because it's very important to do something safe and not just do it for the sake I can do it.
Thank you, Dr. Aljammal. And I have a comment actually about what you were just saying about follow-up, how vitally important that is. My understanding from multiple interviews that I've done with physicians who do this is that thyroid cancer in general, that follow-up is critical, and that you cannot just take that diagnosis and then go home and never go back to the physician for a follow-up, because those recurrences can happen years, decades out. And so I agree wholeheartedly with what you're saying, that the follow-up is critical regardless of the treatment protocol. So Dr. Camacho, did you have any thoughts on this topic about research on thyroid cancer treatments for thermal ablation?
I think there's multiple groups that are trying to really make an effort to push the research arena specifically in minimally invasive therapies of the thyroid. I can speak for the Society of Interventional Radiology, which I'm a member of. I led the research consensus panel for the society, which was a multidisciplinary consensus. And it was done earlier in March this year, and the paper is published already in the Journal of Vascular and Interventional Radiology. And we came up with the research priorities. In terms of malignancy, I think that there's a couple of critical areas for research. Number one, patient selection is critical. I think that we have an idea of which patients need or can undergo ablation, but that's still to be determined. Number two, there's truly not a lot of multi-institutional studies performed. In other words, the vast majority of the studies have been case reports or case series or what we call a single arm study. And in order for this technique to be universally accepted and move the dial from being a recommendation 3A or 3B to a number one recommendation, we need to be able to replicate these results in a multi-institutional fashion. So that still needs to happen. And number three, eventually, and I'm not sure, I mean, this is part of the discussion that we're having among experts, is that I'm not sure how we're going to move that dial when it comes to challenge the standard of care. Right now, the standard of care is surgery. I'm not sure if there's a possibility in which at one point we can randomize patients to surgery versus ablation, or active surveillance versus ablation. I'm not sure that that's something that is feasible, but certainly there's groups trying to answer the most important questions right now, which is number one, patient selection, and number two, reproducibility of the techniques. And I think that that's the key. There's some debate in the literature, and sometimes I hear this in the head and neck meetings or in the endocrinology meetings about which one is the best technology. I think that honestly, in my opinion, for cancer, that is absolutely irrelevant. That's a waste of time of research. I think that thermal ablation for small volume disease, it's equally good. There's some people that are going to say laser is great, but it has more recurrences. Radio frequency is great, has less recurrences. Microwave is faster, potentially less recurrences. I don't think that that's a relevant area of research. I think that the important thing is to make sure that people go to a practitioner that is comfortable utilizing a skill set, whichever it is, and make sure that he does it well. So I think that that's the research that we don't want to hear about.
Thank you, Dr. Camacho.
I'm just going to add, sorry, Jennifer, I'm just going to add
ahead.
one simple comment about patient selection, as Dr. Jonathon and Juan already mentioned about importance of selection and how hard it is. So in 600 patients, and I have few patients who had microscopic cancer, up till this day, I did not even treat one single patient with a papillary thyroid cancer. You cannot find that perfect candidate that meet the criteria. And when I found one patient in the last, I would say, years of practicing, the patient elected to do surgery. Still feel like the standard of care is the best option for them. So this is the importance of really selecting the patient. I've done 600. I still did not find more than maybe a handful of patients who may qualify. And when you find them, some of them do not really want to do. They want the definitive treatment. They want to know this is done, this is gone, because we don't have long-term data. We don't have a extensive long-term data to tell us what's the outcome in the future. All our data is 4 years, 5 years, retrospective. There's nothing extensive, multi-center to answer that question.
Thank you, Dr. Aljammal. And I think it's important to validate those patients who would prefer definitive treatment with surgery. And I agree that those patients do exist. I may be slightly, my population may be slightly different because we see so many patients who just really want to avoid that surgery, and they're interested in the potential mid-step of trying an RFA or a different thermal ablation procedure before a potential surgery in the future if needed. So, so the next question I have on my outline.
I'm sorry to interrupt.
Yes.
We have a question in person.
Oh, wonderful.
Yes, thank you for taking my question. My question is, how much doing the ablation is complicating possibly future histopathology? So once, let's say it's 4 years later, for whatever reason it grew, whatever happened, you need to have a surgery. Does that complicate the pathology read later? And then my other question is, any any advice on the nanopulse, or how much do we know about the newest ablation?
So I'm happy to take the first part because we've done a study about this as well. And this is not necessarily having to do with malignant tumors, because with malignant tumors, once you've had a diagnosis of malignancy, no future benign biopsy necessarily undoes that. Although there are significant numbers of studies coming out of Asia that have tried to biopsy or core needle biopsy the area of the previous cancer and have not found malignancy there. We also know there are surgery series that look at these post-ablatement surgeries and have, in some situations, found cancer that is still residual there. So I think it's a mixed bag. But instead, talking about benign tumors, there are some studies that look at long-term outcomes 3, 4, 5 years after treatment. And it seems like for the most part, subsequent biopsies and both cytology from a fine needle aspiration and also surgical histopathology, both of those seem to stay benign consistently in the future. I think all of us have had experiences where that has become a little bit complicated. And at least in my experience, when it has become complicated, oftentimes there's a driver mutation that is involved, but these driver mutations are almost pre-malignant rather than true malignancies. And that's in my limited experience. I don't know that there's anybody that has a huge number, but that's the first part of the answer.
Thank you.
I can answer the nanopulse question. We have it available in our center, and currently it's only being used for benign nodules. Okay, we have no data, and there is no data in the literature or presented about the effects of nanosecond pulse electric fields for the treatment of micropapillary thyroid cancer. So at least it will be a few years before we hear that it's ready to go. So right now, I would not recommend nanopulse pulse electric fields as an ablative modality for micropapillary thyroid cancer because we just don't have the evidence. It hasn't been done yet.
Thank you. And I have a quick follow-up question. I mean, I know that it was mentioned that it's only tried for micropapillary cancer. Has anyone tried this for oncocytic 1 centimeter, like a AUS, so Bethesda 3 tumor?
So I would like to jump back and forth with a couple of comments here. Just when we are talking about fine needle aspiration, remember when you have fine needle aspiration, you're looking at statistic, likelihood of being malignant or not. So if you have biopsy that came back benign and then you did thermal ablation and later you got a different pathology, it could be just a missed cytology more than anything else. And up to my knowledge, most of the retrospective, post-surgical evaluation, there's few cases that show maybe missed cancer or maybe converted after, which basically was follicular carcinoma. So up to my knowledge, really thermal ablation does not change histology. Using pulse technology is still in very early stages. We still don't have any published solid data about outcome of pulse and benign nodule to kind of talk about that in the microscopic field. From what we call indeterminate thyroid nodule, we have currently a study is in the process of being published, and we compare data of indeterminate thyroid nodule with negative genetic testing. Those, the likelihood of being malignant is similar to a benign cytology, so still can miss cancer, but the outcome, which is hopefully we're going to publish it soon, does not show any difference between benign cytology and negative genetic indeterminate nodule. Now, a oncocytic, and we're talking about follicular neoplasm, this is a little bit of a controversy in literature, but a lot of physicians do not feel comfortable. Most society do not recommend considering treatment with follicular neoplasm tumor. I think in our data, we have only 2 patients in that sample who have negative genetic testing. Again, estimated risk is 3%. And their outcome, again, we're talking about volume reduction. We're not talking about long-term outcome. We're talking about short-term. Their volume reduction is similar to benign. But does not translate to we have long-term data about how they perform those patients over 5 years, 10 years.
Thank you so much, Dr. Aljammal. We have reached the end of our time today. Thank you for all of our speakers joining me today, and thank you for all of you attending this session. It's been a pleasure.